think we're just about ready to start here. Again, welcome to everyone. This is the right place if you're looking for the Sunday Health webinar. We're going to be talking about brain health breakthroughs. I think we're ready to go ahead and get started here. Thank you for everybody who joins. We're very excited to start this webinar and excited that you're able to join us today. Quickly about Sunday Health. Sunday Health is a medical practice, as you can see here. We are very much dedicated to preventive, diagnostic, and ongoing cognitive care. We are live seeing patients in DC, Maryland, and Virginia. And if you haven't learned more about us, hopefully you can learn some today, and feel free to reach out to us with any questions after this webinar or an ongoing. Just as a quick agenda for today, we are talking about brain health breakthroughs. We're going to look at the latest research on prevention. We're going to go into some of the new innovations that are facilitating early detection, as well as talk about the first disease-modifying treatments. And we will have a Q&A at the end. We're going to leave time for that. Feel free to put your questions. Again, at the bottom of the Zoom screen, there's a Q&A there. And there is a box that you can press that makes that anonymous if you'd like to keep it anonymous. We will try to get to as many as we can at the end, but please realize we're not going to have time to get to all of them, but we'll do our best to address as many as we can. And again, after the webinar, if you have any questions, please feel free to reach out. There is a caption button at the bottom of the Zoom. You can turn that on as well. And this will be recorded. So if you want to watch it again later, or if somebody who's not here today and you want to tell them about it, then that will be great for them as well. So for quick introductions, I'll start with myself. I'm here with two fantastic physicians, Dr. Amy Sanders and Dr. Clay Ackerley. I'll have them introduce themselves right after me. But by quick way of self-introduction, I'm Dr. Doug Elwood. I'm the Chief Medical Officer here at Sunday Health. I oversee all the clinical activities and the care model. I'm not one of the actual physicians, so if you do go through the Sunday Health model, which I hope you will, then you won't be seeing me, but I am absolutely open to feedback on the process and any ways that we can improve and learn from your journey with us. Just quickly about Sunday Health, as I just mentioned, we are a cognitive care practice. We're live in DC, Maryland, and Virginia, and we are actively seeing patients with no wait time. But this is not about Sunday Health. This is about what gets us excited every day, and that's the breakthroughs that we really feel are coalescing to form a watershed moment in this field. And you have different items coming together in a convergence of diagnostics, therapeutics, and interventions that are really reshaping the field and how many are looking at it. And we're really excited to talk about that. That's really the purpose of today. We're about to get started. Before we do, just to go over some quick logistical items. Again, thanks to everyone who submitted questions. We're going to try to get to a lot of those. You do have a chance to enter questions down at the Q&A as we go. This session is being recorded, as I mentioned, so you could watch it later or let others know that they can. And you can also turn on captions, as I mentioned. So with all that said, we're going to go ahead and introduce our speakers, again, both of whom I'm excited to have here today. Why don't we start with you, Dr. Clay Ackerley.
Wonderful. Thank you, Dr. Elwood. It's great to be here. And I know a number of my patients are here today and have had the chance to meet with the Sunday Health team. So thank you to Sunday Health for your care of my patients, and certainly excited to be a senior clinical advisor to the Sunday Health team. My day job is as a practicing primary care physician. I've had a long-standing interest in the care of older adults, and one of the biggest, meatiest, most challenging topics that we handle together is how do we tackle and optimize our brain span, as the term of art is coming. So how do we not only extend lifespan, but also brain span as we age? So excited to be here and dive into this important topic.
Excellent. Thank you, Dr. Ackerley. And Dr. Amy Sanders.
Thank you, Doug. Yes, so my name is Amy Sanders, and I am a dementia neurologist, and I've been in practice since 2008. And for most of that time, dementia neurology was a sleepy, quiet little backwater where, people would come to see me, not really believing that there was much I could do for them. There were always things that I could do to help, but I've always believed that older adults, even if they have cognitive impairment, even if they have dementia, can still live high quality lives. And it has been my mission. The reason I went into this field is to help people do that. As Doug mentioned, we have now reached a watershed moment. I mean, these days, this is one of the most active, most interesting, most exhilarating areas of medicine because now we have greater precision in our diagnostic testing. And for the first time ever, and just in the past, what would it be, about 15 months, we have not one, but two on the market disease-modifying medications for sort of a middle pre-Alzheimer's kind of state and the mild stages of Alzheimer's disease. And the clinical trial pipeline of new medications for these dreadful diseases is active and pumping out new medications, and that is also really exciting. So exceptionally exciting times. I want to welcome anybody who I've already met at Sunday Health, and come see me if you haven't yet.
Perfect. Thank you, Dr. Sanders. So let's dive right in. Dr. Ackley, I'd love to start with you and talking about prevention. If you can fill us in on some of the latest and greatest from a research perspective, and also just what's important to think about as we talk about prevention.
Absolutely. I think the term sort of preventing dementia up until recently was seen as almost an absurd thing to say, but increasing research is showing that yes, many cases of dementia can be prevented. I think the seminal work is the Lancet Commission that anybody can look up online that goes through all of the various modifiable risk factors for the various types of dementia, whether that's vascular dementia, Alzheimer's type dementia, and the other related dementias. There are non-modifiable risk factors, right? Those including genetics and environmental exposures and things that have happened to us already in our past. We can't change what has happened to us. If we were smokers when we were younger, if we did play football and have a lot of concussions and traumatic brain injuries, there are lots of things that have happened to us that define where we are. But looking forward, there are a lot of modifiable risk factors, whether you're 30, 40, 50, 90, that are worth looking into. Some of the most recent research that has been exciting to me is how things like vision optimization, hearing optimization. Yes, we know that being socially engaged is important for our quality of life, but improves our brain health. A lot of things that, I've had patients say, well, Clay, you're telling me the things I already know I need to do around cardiovascular risk management. But yes, having your cholesterol under good control, blood pressure under good control is not just about preventing heart attacks. It's about optimizing your brain health. Smoking is one of those things that hopefully very few people are doing these days. But early on, is say, oh, well, you need to stop smoking so you don't get lung cancer. Well, it turns out you need to stop smoking to help your brain as well. So I think the recognition of these modifiable risk factors that make a real difference, the Lancet Commission saying, 45% of dementias are preventable when you look at those factors. And that doesn't even include a bucket of things that are reversible causes of cognitive decline. So if you are worried about your brain health, yes, there are things that you can do to prevent the progression of dementia, but there are a lot of things you can do to improve your cognition in the near term, not just prevent dementia down the line. Sleep optimization, mood optimization, reduction in unnecessary substances, alcohol or otherwise, thyroid health, vitamin health. B12 deficiency is more common than we'd like to think. So, as we look at those modifiable risk factors, as we look at the ways that we can help optimize our cognition, that list is very, very long. And I do have to say, again, this is about these changes in research, but I have to plug, again, the Sunday Health team. This is something I care deeply about. But as an internist, I feel both like standing on the shoulders of giants when there's all this just massive work that's been put into this field over prior decades, but also a little overwhelmed in the clinic saying, I need help thinking through What's the right combination? How do we prioritize these changes in our life? We can only do so much. There are conflicts, right? Sometimes we know that high exposures to anesthesia have a cognitive consequence, but you also need to walk and exercise, which is really important for your brain. So how do you balance anesthesia for a knee replacement and the mobility and exercise that come with it? So it's not black and white. There are trade-offs that need to be made. But having a team to help think through these things is really, really important. In addition, one of the realizations that the field has come up with, and I think was in retrospect somewhat common sense, but there's a long preclinical phase to dementia where small changes are happening to our brains after our brains stop maturing. And so whether it's in your 30s, 40s, 50s, 60s, and beyond, now's the time. It's never too early to get involved in optimizing your brain for the long haul.
Yeah, it's such an important message. Thanks, Dr. Ackerley. And I mean, you mentioned, first of all, the Lancet Commission, which is in the chat there for those who want to take a closer look. As Dr. Ackerley mentioned, it can be found on Google and has just a great amount of detail on those modifiable risk factors. And as you pointed out, 45%, just staggering, and that long timeline. So lots of chances to improve, lots of chances to be proactive and really change the way that we're thinking about it and approaching it. Really appreciate that, Dr. Ackerley. And let's shift now. And
Could I jump in here for just
absolutely.
one second?
Yeah,
Both of you have mentioned the long timeline. So what they mean when they say the long timeline is decades. It's not months. For most people, it's not years. It is probably decades between the time that unhappy pathological changes that ultimately could lead to dementia start happening in the brain, decades potentially before clinical symptoms appear. And even after clinical symptoms appear, there still are ways that you can improve your situation. So I really, really want to underscore and drive home that notion of it is never too late to make healthy changes for your brain. Healthy mind in a healthy body.
very good point. Thank you, Dr. Sanders. We are seeing folks raise hands. Please submit your questions, as you can see in the chat during the Q&A. And we will, or submit your questions in the Q&A, and we will try to get back to them in the Q&A session at the end, and we'll try to get to as many as we can. I know a lot of people have questions around that important area of prevention. We are going to shift now into detection. I'm going to come back to you, Dr. Ackerley, if you don't mind giving us a little bit of insight on what we mean by biomarkers, and then I'm going to ask Dr. Sanders to go into those more deeply. But if you can just tell us, what is a biomarker? Why is it important? How should we be thinking about it?
Absolutely. Biomarker simply is a marker of biology, a quantitative measure of something important to our biology. For a long, long time, I was taught in medical school, the only way to diagnose Alzheimer's disease was based on autopsy, right? Then there were measures of cerebral spinal fluid and specialized PET scans, and getting better and better. The most common biomarker that we think of, although you can consider a blood pressure that you can do at home a biomarker, but are blood-based biomarkers. You get them all the time when you're checking your cholesterol, looking for diabetes. And for the first time, and what is foundationally exciting to me, is we're beginning to see these blood-based biomarkers turn out to show real value. It's early, and there are a lot of them, and we're still trying to figure out how to apply these most appropriately to each of our patients. But this era is here, and so I'll let Dr. Sanders dive in there. But I think a biomarker is just a measure of your biology, and now that we've got blood-based biomarkers for cognitive health, it's gonna change a lot. But I think we're in the first innings of something really, really meaningful and powerful.
Absolutely.
So I'd like to just two comments here. One, I keep hearing at the big meetings that I attend about Alzheimer's disease and other dementias that really we should not be thinking of these as an either you have it or you don't, black and white, yes or no kind of situation. We should be thinking of this more as a continuum, a la the way that we think of atherosclerosis ultimately leading to heart disease.
Mm.
And you get changes in the brain that lead to brain disease. And that brain disease often manifests itself through cognitive changes or cognitive impairment. It is still, to this day, the case that to make a definitive diagnosis of a disease that causes dementia, we still need tissue. We don't, generally speaking, do brain biopsies while an individual is living. There are rare exceptions, but fortunately they're rare. But to have a neuropathologist examine brain tissue after somebody has died under the microscope, that's still the only way to be definite about what somebody had. What the blood-based biomarkers and the spinal fluid tests and MRIs and specialized PET scans allow us to do is, in our clinical diagnosis, be much, much more precise than has ever been the case before about the likelihood that the changes that somebody is experiencing might be due to underlying things are most advanced in terms of Alzheimer's disease. I think the other dementias will catch up in time. So still tissue for a definitive diagnosis, but greatly enhanced precision of diagnosis using the biomarkers that are now available to us. Dizzying array of biomarkers are now available
Yeah,
to us.
and,
So
and
exciting.
tell us about them, Dr. Sanders, if you don't mind. Give us a breakdown of what they are and why we should be interested in them.
So a few words about imaging, and really only a few words. We use MRIs, structural imaging, to give us sort of a picture of what the structure of the brain looks like. That can be quite helpful to me. It lets me know, has blood pressure, diabetes, cholesterol caused damage to the brain? We can see that through what you'll see on a radiology report described as white matter changes. We can also measure the size of a structure called the hippocampus. You have one on each side, roughly around your ear. And the hippocampus is very important for the initial processing of incoming new memories. And we can, through what is called post-acquisition software processing, that's all you need to know about that, happens after the pictures get taken, and they can actually measure the volume of this structure called the hippocampus. And you generally will get from the neuroradiologist reading the MRI report that the hippocampi are X% of what would be expected for age. You really don't have to get too worried unless that X% is 5% or lower. So that's brain MRI. PET scanning, kind of a glorified X-ray. It's a quicker test than an MRI, but it works by looking at, you get injected with what's called a ligand, a different kind of biomarker that circulates through your bloodstream and ultimately binds with certain proteins in the brain, allowing us to see in clinical practice abnormal Alzheimer amyloid protein that has been deposited into the brain tissue. Not yet ready for clinical prime time, but very active in research, is the same ability to look at a different protein called tau. Then we get to the fluid biomarkers. In order to have any of your fluid biomarkers tested, previously you had to have a spinal tap. Nowadays, you can have a blood test instead of a spinal tap, and I don't think I know anybody who would prefer to have a spinal tap over a blood test. So one of the reasons that we're also excited about this is that we now have these biomarkers that we can test on blood. Much greater access for patients, much less invasiveness for patients, and a wider array of information for physicians like me. And data is now coming in to show that the blood-based biomarkers are probably the equal of the cerebrospinal fluid, the spinal tap biomarkers. So that's very exciting. All right, we've talked about them. What are these blood-based biomarkers? Let's get specific. So there's one called the amyloid ratio. And this is a test that is exactly what it describes. It is a ratio of abnormal Alzheimer-prone amyloid protein and normal amyloid protein. Everybody has amyloid protein. Some people have their amyloid protein gets processed incorrectly, and that can lead after potentially as much time as decades, to Alzheimer's disease. So we look at the ratio, and the way that this test gets resulted is it'll say that the ratio is lower than normal or okay. And the reason that the lower than normal ratio is considered the abnormal result is because as abnormal amyloid protein gets deposited into amyloid plaques in the brain, it circulates less through the bloodstream. So very logical. There is also a protein called tau that makes you may have heard of the neurofibrillary tangles. And there are now 2 forms of tau, both involved in Alzheimer's disease, that we can check. And here, generally speaking, if your values are elevated of either one of these, one is called p-tau, P standing for phosphorylation. That's biochemistry. You don't have to worry about it anymore. Just know that when that tau gets abnormally phosphorylated, that's a problem. And we can check 2 different forms of the tau protein that have abnormal bits of phosphorus hooked to them. Then there are 2 tests that sort of give us a sense of whether ongoing neurodegeneration is occurring. So neurodegeneration is a very general phenomenon. It occurs in multiple sclerosis, in Parkinson's disease, in Lou Gehrig's disease, and in any kind of dementia. And there are 2 tests. One is called neurofilament light chain, or NFL for short, and the other one is called glial fibrillary acidic protein, happily GFAP for short. And that those 2 proteins, NFL and GFAP, both give us a sense of whether neurodegeneration is occurring. And there probably are going to be ways that we can use those 2 markers, theorized at this point, not fully fleshed out, but to track over time how somebody is doing. Do they appear to be prone to or vulnerable to progressing in their cognitive impairment? And that's even more exciting, because that's not just is there a problem or isn't there? It also kind of allows us to sort of adjust up or down our expectations of when and how we expect that things will change. So that's the brief overview of biomarkers.
Excellent. Thank you, Dr. Sanders. And in the chat, we did drop some more information about the blood-based biomarkers and Alzheimer's. And just as a quick summary, because I'm sure there's a lot of questions and some big words there, but really there's this new class of biomarkers. And as Dr. Ackerley described, the biomarkers are, things that we're very well acquainted with, from blood pressure to substances that are in your body, like cholesterol. And as Dr. Sanders has described now, we are able to measure some of the things going on in the brain and some of the deficiencies that are happening as they represent in the blood. So some really exciting evolution in our understanding of what's happening. And as Dr. Sanders really nicely articulated, it's a continuum. So it can help us identify and potentially monitor progression as we go. So things we're still learning about. Dr. Ackerley, there's a question right now, and in general, are patients asking you for these? Are you using these in your practice? How are you approaching this?
Yep, absolutely. So I think they are early days, and but there's enough promise that I have been asked about them, and I certainly have ordered these a number of times. I do caveat that not exactly sure 100% how to interpret them. It is the strongest use cases for someone with notable, and Dr. Sanders, please correct me, with noticeable cognitive impairment, to say, okay, could there be Alzheimer's pathology? And I know that the drug companies who are looking at the disease-modifying agents there that Dr. Sanders will talk about in a minute, that the blood test can help say, okay, you might be appropriate for these sorts of treatments. So it can help with some of the teasing out of the clinical diagnosis and saying, are you more likely to have Alzheimer's pathology versus not? There are, marrying that with genetic factors, the ApoE, gene can help us understand future risk, and that can be frustrating or empowering depending on how you look at the data and what your result is. I don't want to go down a rabbit hole on that one, but the 4 genotype is the highest risk for Alzheimer's disease. In any gene, you've got 2 copies, one from mom, one from dad. And if you've got 2 of the 4s, that does put you at meaningfully higher risk. If you've got 1, not 2, a small increase in risk. So that can be helpful in my patients who also have a family history of Alzheimer's disease to understand, what may have happened to mom, dad, other family members. Might they carry that gene? But that's just one of many, and we are looking at other genes as well that may play a part. So the answer is we are using them. We are trying to figure out how to put this all together for each of our patients in the right way. And but it is an exciting time for sure.
Makes sense.
Right. I would suggest that yes, I absolutely agree with Dr. Ackerley that if there is somebody who has notable, measurable, or very bothersome cognitive impairment, that then these tests can be very useful because they give us a sense of how likely is it that the cognitive impairment is coming from an Alzheimer-like process versus something else. And we're not very good yet at describing what that something else might be, but it is very helpful to be able to say to somebody, well, this doesn't look very likely to be Alzheimer's disease. Remember, these are not, they're described frequently, just to confuse everybody, as diagnostic tests, but they are not precisely diagnostic tests. In other words, if you rule in for one of these tests, that does not mean that you absolutely positively have Alzheimer's disease. It is a very important building block in that diagnosis, but it's not unto itself sufficient to make that diagnosis. That being said, I would say if somebody has a very strong family history, that would be an argument, even if they are clinically asymptomatic, potentially to have these tests done. If there is puzzlement about why is somebody having cognitive impairment, especially if there are other problems, like problems with sleep or problems with depression or anxiety, that might be another reason to do it, primarily just to see how much attention do you need to be paying to the possibility that this is Alzheimer's disease. So those are some areas in which it can be advisable to have some of these tests run, even if one doesn't have notable cognitive impairment. We are also, now that we have them, we're learning about other ways in which they are useful. So Dr. Ackerley mentioned the apolipoprotein E genotype. Genotype just means your genetic status for a thing. And the apolipoprotein E, shortened as ApoE, is a major risk factor for Alzheimer's disease. But now we're also learning that in certain forms of vascular dementia, what one's ApoE genotype is may influence their risk for further development of their vascular disease. So that was not something that I knew about 2 years ago, but I know about it now, partly because we're paying much more attention to ApoE testing.
That's right.
Maybe 2 more quick points on this. One is, if you, as Dr. Sanders said, we may want to test in someone who doesn't have symptoms, and there are reasons to do that. If you have a positive test, do not fret. It's not yet entirely clear what that might mean for your progression, but also we know that there are patients who have, on autopsy, brains riddled with amyloid plaques and are cognitively normal. Right? This is complicated, and we're learning everything. We're learning so much every year, every month, every week. It seems like. But I don't, want these tests to be a source of anxiety. Hopefully, they can be a source of proactive engagement and a better understanding of one's own biology. We were in a similar position not that long ago with cardiovascular disease, right? Trying to understand, what does LDL mean? What does HDL mean? For people who had their cholesterol checked 20 years ago, like, well, HDL is protective and there's ratios, and we're getting more and more fine-grained understanding of both cholesterol measurement on risk and tracking response to treatment. And I think we'll get there fairly quickly with this as well.
Right.
Yeah,
So one thing that Dr. Ackerley just very helpfully did, and thank you, and shame on me for not thinking to do it, but he explained why these new blood-based biomarkers are not considered to be fully diagnostic, because we've been able to see abnormal amyloid protein on PET scans for over a decade now. And we know that people have positive amyloid PET scans, meaning that gets you into a clinical trial, that makes you potentially eligible for one of these new medications. But what if you're completely asymptomatic? We know that those people exist. We don't yet know what they mean. Are they eventually going to get Alzheimer's disease? They just haven't gotten old enough yet? And does old enough for that person mean 132 years, not 82 years? We don't know. And this is why we don't consider the tests yet to be diagnostic. But boy, do they help with sort of our diagnostic, the calibration of our diagnostic theorizing.
That's right. Thank you both. Really good explanations and ways to think about that, and already addressing some of the questions in the Q&A as well. And as a reminder, there will be a recording of this. Dr. Sanders, and both of you have mentioned the link to treatments. If you don't mind, Dr. Sanders, on just telling us more about the disease-modifying therapies, a 5-minute crash course on what they look like, what they are, how to think about them, that would be great.
So I am not a biochemist, full disclosure, and I don't expect that anybody in the audience, boy, I sure hope, in fact, that there are no biochemists in the audience, but I'm going to reason initially by analogy. And I want you to think of your brain as a thriving urban neighborhood. Perhaps you're getting a little bit older, and suddenly there's a problem with trash accumulating. And by trash, I mean abnormal Alzheimer's protein. And wouldn't it be nice if there were garbage collection that could come and get rid of this abnormal amyloid protein? Well, garbage collectors are great, but you want to make sure that they're also not taking away your dining room table and your bedside table and your couch and your flat screen TV. You want them to be able to target the trash for removal. And that's kind of how a monoclonal antibody functions. I'm going to unpack that terminology a little bit. An antibody is basically how your body's immunological systems function. An antibody is a little bit of protein that can sort of mark another protein for removal, for clearance. And so we have these monoclonal, they're engineered in a lab to be one particular kind of cell. And this kind of cell, this bit of protein it's not really a cell, but it's a bit of protein that will circulate through the bloodstream, go into the brain, target abnormal amyloid protein, flag it so that the body's regular cleanup mechanism, its normal cleanup crew, can come in and see these tagged, flagged, abnormal bits of amyloid protein and remove them from the brain. And that is what, if you read the papers that have described lecanemab, the first monoclonal antibody that was ever FDA approved for the treatment of Alzheimer's disease, it is on the market as Leqembi, a Japanese word for something along the lines of beautiful or flowery, something like that, so a happy word. And donanemab, which is an Eli Lilly medication that was approved just a couple of months ago, and its brand name is Kisunla, and I have no idea what that means. But both of those medications target abnormal amyloid protein by engineering these antibodies in a lab, formulating them so that they can be injected into somebody's arm every 2 weeks for lecanemab, every 4 weeks for donanemab. And then those monoclonal antibodies circulate through the bloodstream, go to the brain, where they tag and flag abnormal pathological Alzheimer amyloid for removal. Tau monoclonal antibody treatments are not yet FDA approved, but they are coming close. They are already in mid to late stage parts of the clinical trial pipeline. So that is just exceptionally exciting stuff. These new medications, lecanemab, donanemab, Leqembi, Kisunla, are FDA approved for people who have mild cognitive impairment, a pre-Alzheimer's disease state of cognitive impairment, but the mild cognitive impairment is felt to be due to abnormal amyloid, abnormal Alzheimer pathology, or for people who are in the mild stages of Alzheimer's disease already. In order to determine whether somebody's eligible to get one of these medications, you actually have to have a pretty big workup. That includes brain MRI, basic labs, probably these days, Alzheimer blood-based biomarkers, in some cases, probably then also perhaps an amyloid PET scan, or if people would prefer, I don't generally speaking meet people who prefer this way, but evidently in Europe, this is how they think, who would prefer to have a spinal tap instead of a PET scan. But the data is really so strong in support of the blood-based biomarkers as serving as that, yes, I have abnormal amyloid pathology, so I should be eligible. We're not yet using the blood-based biomarkers in order to make that determination in a formal way, but we are getting close. I would expect, actually, I wouldn't be surprised if within the next year, if we are starting to do that.
Excellent. Thanks, Dr. Sanders, and thanks for that
Did I
analogy.
do that all in one breath?
Yeah,
It feels like I did.
Nicely done, nicely done. So we just ran through a lot. We ran through prevention, we talked about early detection, we went through some treatment options and what's coming out on the market. Obviously, we're moving fast. There's a lot. You can see we're excited about it and trying to cover all of it. Again, we're going to be having a recording of this, and there's more. We're going to post a link to Dr. Sanders that she talked more about some of these treatments in a different setting if you're interested. But we'd love to open it up for some questions. So some of you have already dropped in questions as we've been going along, and others submitted beforehand. Thank you for those. As you think about and drop some additional questions, and if you're interested, you can see here, thank you for putting that up. There's a Q&A button down at the bottom, and you can send them anonymously. Just click that button there, as you can see. We're going to start with a question that we got that is around access, and extremely important in this topic, and a big reason why Sunday Health partly exists. And the question is, why is it so hard to get a neurology appointment? Wait times of 3 months in this instance. Really frustrating, and we definitely understand that. And again, is a big reason why we feel Sunday Health is important in this discussion. There are areas of the country where there are no neurologists or very few. There's a term in general for a lack of practitioners called a desert. There are neurology deserts in most areas of the country. And even where there are
including in a county in Virginia, right near DC.
That's right. That's right. And even where there are neurologists, because the demand can be so high, there are wait times that are very typical, reaching up to 9 to 12 months. So one of our goals here at Sunday Health is to enhance access and get people seen and have this discussion much earlier on. And I'm glad we're having this webinar today because it keeps the conversation going. So thank you for that question. I know it's really frustrating. I know there are a lot of questions that come up with this topic. It's extremely important to get the right answers and understand where you are in your own or your loved one's health journey. So we hope to help with that process as much as possible. So I am
also one thing is if you happen to live or have loved ones who live in a neurology desert, there just isn't good availability of neurology care where you live. This is one way in which telemedicine, one of the few good things that came out of the pandemic. Telemedicine was not a thing before the pandemic, and after the pandemic, it was most assuredly a thing, and we hope a permanent one. But it really allows us to expand the reach of what neurology services are available to improve access in areas where there just isn't any.
That's right. So one question that's come in again is about, I understand the excitement about what is being discussed, but how much goes in to current practice? Maybe Dr. Ackley, if you can start with that, and then we can move to Dr. Sanders.
Yeah. So I think we're using this in current practice today. As I mentioned earlier, we're beginning to use these blood-based biomarkers. The treatments that have come on in just the last 18 months are appropriate for certain patients. We know, and for those who have heard a lot of the negative press about the treatments, yes, there's plenty of downsides. They are expensive. They have side effects. They require IV infusions. But also the pipeline for treatments. And there are over 150, I think, clinical trials currently underway, a lot of which, have a lot of excitement. And so at the quote unquote, bench to bedside in research, there's a lot at the bedside that the excitement is we're feeling it, and also a large pipeline that's coming. And I think one of the things that makes me want to dive in now is the importance of baselines, right? So you may have a little bit of sleep apnea and a little bit of brain fog, or the election's coming and you're anxious, and that's leading to some brain fog. You're like, oh, is this me in some early MCI, or is it something else? Well, you know what? Let's get a baseline. And we can even, if appropriate, get a blood-based biomarker baseline, and 10 years from now, we'll actually be able to say there has been now a change. Well, so the bottom line is, I think it's here and it's going to get better. And just like, our understanding of lipid, I know I've used that example a lot, but it's true. We're getting better and better with lipids, and they've been around for a long time. We're going to continue to get better, but this is here. And I think it's worth everybody to be proactive, as well as understanding that this is still early days of now. Instead of head in the sand, I don't want to know, there's nothing we can do about it. Well, guess what? There are things you can do about it.
And there always have been.
There always have been. And I think we now have increasing evidence that they are important. And I do feel pretty badly for a lot of my patients who have enjoyed their 2 glasses of wine a day, because that's what medicine has said is like heart healthy. And oh, by the way, alcohol is not good for us. I'm sorry. So there are things that change on us that always leads to certain frustration. And yes, there will probably be things that we are doing now that 10 years from now, even 5 years from now, we say, well, we wish we had known different. But this is like, it's here.
Yeah, absolutely. The biomarkers are being used, and Dr. Sanders, I'm going to ask you about that in a second. The treatments are being used, and Dr. Ackley, probably most importantly to your point, is that the prevention and the thinking about it in a more holistic way and building in some of these other measures are absolutely here and have been present with other disease states for a while, but are now really being understood for the brain and how important they are. But Dr. Sanders, you're ordering these labs. Can you tell us a little bit more about that? And also, if you don't mind, just mentioning, go into a little bit more about the efficiency of the blood tests and the efficacy and if insurance is covering them.
So let me tackle the insurance question first. And my short and sweet answer is yes, but your mileage may vary. Insurance, as I think we all are painfully aware, is not monolithic. So my understanding is that these tests are, for the most part, covered by Medicare. I have been assured in the past by reps from one of the lab companies that they would never balance bill a Medicare patient, meaning that if there's a difference between, or this is how I understand balance billing anyway, if there's a difference between what Medicare would pay and what the lab charges, the patient is not going to get a bill for that difference. The lab will just take what Medicare pays them. But I think that not everybody has Medicare. Some people have private insurance. Some people have no insurance. I think in some cases, it might be possible just to walk in off the street and say, yes, I want these tests. It's probably not quite that simple, though, because the menu of tests that you can order that way does not actually include any of these tests. And I think that one of the companies did have one of these tests, the amyloid ratio, as a, you can walk in off the street and order it kind of test, and they don't do that anymore. So you probably, for the most part, need a physician to order these tests for you. I have not heard anything about people being told that the tests are not available when they go into, most people go either to Quest or to LabCorp. And as far as I know, these tests are widely available in both of those settings. They should be covered by insurance. I think occasionally insurance might deny, but if that should happen, there's a mechanism where people like me can go to bat on your behalf with the insurance company to plead your case and say, this is why it's important that these tests be ordered. And we're all just learning about them. So, one insurance company in one part of the country might be, really, really au courant with all of it. And the same insurance company in another part of the country, the people there just might not know as much. So talk to your physicians, talk to your medical practices, call your insurance company, and then sort of, watch this space. Not this specific space, but in general, the space of people who update you on, sort of how things are developing in terms of medical practice. So that's the answer, as best I can give it anyway, to the insurance question. They're very easy to order. So there shouldn't be an access problem. But as Dr. Ackerley mentioned, and I think that for many primary care practices, this is all very, very new. And boy, there is a lot of it. So learning what it is, how to use it, and what it means, how to interpret it, is a non-trivial process for most physicians. And, I'm just thrilled and excited. I bound out of bed every day because it's just so exciting what I'm doing in my work these days. But I can see where that could be daunting and kind of overwhelming for, a busy primary care practitioner who just doesn't have time to take into account all of this new information. That will come. I mean, think about 30 or 40 years ago in diabetes. We had insulin and not much else. And now, boy, diabetes has really become an easily manageable disease. It's still a very serious disease, but we have GLP-1s now and all kinds of other medications. There is a menu of medication options, not just insulin. So in Alzheimer's disease, we are at the just insulin stage of things. So again, watch this space. And 30 years from now, the conversation is, I'll be long since retired and probably dead, but the conversation will be as different, I think, for Alzheimer's disease as the way that conversations about diabetes are so vastly different than they were 30 years ago.
Thanks,
I'm not
Dr.
sure.
Sanders.
Did I get all parts of your question?
I think you did. I think you did. Thank you.
I think 30 years is a little bit long.
Yeah.
That's probably true. That is probably true. We're probably much faster now. Yeah.
But sticking with the treatment, and both of you have appropriately used predicates as great examples. So either atherosclerosis or other components of that. So I appreciate that. I think it helps paint a really nice picture for everyone who's listening. Dr. Sanders, just to go back to one of the points you mentioned, there's a question around the monoclonal antibodies circulating in the brain, and as you said, tagging and flagging the abnormal amyloid proteins. The question is, once the proteins are tagged and flagged, then what? Are they removed, and if so, how?
So they for donanemab in particular, in the clinical trials, they actually monitored people serially with PET scans, and they would actually stop the treatment once the PET scans were no longer showing any we're no longer showing any deposits of abnormal Alzheimer amyloid protein. We don't know if that's the right thing to do. There's actually a bit of swirling controversy over that question. But basically, once this is how the body's immunology, its immunological systems work. Full disclosure, immunology might have been one of my weakest subjects in medical school. So it's kind of ironic to me that now I'm talking about it professionally. But the antibody finds its target, and then it manages to work that into the bloodstream and eventually out of the body. I mean, you don't exude it through your skin, but you'll ultimately, you'll get rid of it in urine, in other things will be broken down, metabolized, reused.
Mm-hmm. Yeah,
but we don't yet fully, just one other caution here a little bit, we don't yet fully understand, is complete removal of abnormal amyloid protein really truly the appropriate goal? A couple of decades ago, there was a vaccine that came very, very close to being FDA approved, and it cleared amyloid like the dickens. The problem was that people then had really, really devastating forms of meningoencephalitis, a dreadful, potentially fatal brain disease, brain infection, basically, brain inflammation. And we don't know why that is. But that's a little cautionary tale in the back of everybody's mind about, do you really, really want to get rid of all of the amyloid? We don't know, but it certainly seems to be the case that getting rid of at least some of it is the right thing to do.
Mm-hmm. Shifting back to early detection, Dr. Ackerley, how does one think about, we got some questions around signs and symptoms and how to think about that as, normal aging and, memory issues. How do you approach that in the clinic? And then maybe we can jump to Dr. Sanders.
I mean, it's a complicated topic, and I think almost any subjective symptom of cognitive slowing, I think, is worthy of raising. Whether it's brain fog, cognitive slowness, the wheels aren't turning, but also commonly around naming. Forgot this person's name, I forgot where I was going, sort of for forgetfulness in general. And up until recently, we said, oh, okay, a lot of that is normal aging. And a lot of that is just an aging brain. How much of that we should accept as normal, normal, is an open debate, because we know a lot of the things that can reduce the risk of dementia, as laid out in the Lancet Commission, should also be able to help slow down the normal aging process of the brain. But I think anytime you've got a cognitive concern, raise your hand. Often it can be a sign of thyroid dysfunction, sleep dysfunction, depression, things that are not, neurodegeneration, just neurologic slowing. And so seeing a provider, talking to your PCP, and unfortunately, most primary care physicians are overworked, underpaid, don't have the time to engage. And that's why I'm so excited that Sunday Health exists, because you can also just self-refer and say, I want to have a deeper conversation about it. So I don't think there needs to be any threshold of concern. Also, sometimes in some cases, family members don't notice these changes happening. And so it can be incumbent upon a loved one, a caregiver, to raise the hand and say, hey, I've got a concern. And I would just encourage anybody out there who, when I mention that, they think of a loved one, reach out to that individual's provider and just raise your concerns. No, that provider can't talk to you unless you've been approved, that they can talk to you, but you can always talk to that provider to raise your concerns about a loved one. So I don't know if that answers the question specifically. There's no magic number of times you forget a person's name or where you say, okay, let's get evaluated. That's also why I encourage a baseline cognitive assessment. I say all the time, right? Just, when patients say, I'm forgetting names, were you ever good at names? Right? Most of the time is no, I was never good at it. I was like, well, you're not going to get better at that as you get older. So don't make that a red flag concern. But work with your providers, dive in to potential causes that can improve cognition. Hearing aids, vision, have you had your cataracts replaced? Yeah, are you working on sleep optimization? Are you on medications that can slow the brain down? I am surprised, even though I talk to my patients all the time about antihistamines and the challenges and the harms from sedating antihistamines, that people say, oh, I'm not taking any sleep meds. I just take my Unisom or Advil PM every night. It's like, okay, let's talk about that. So think there's lots of.
And if you're taking Advil PM every night, please stop. Don't do that. It's not good for you.
And there's now new data. This is, again, a complete tangent. But Dr. Sanders, you'll appreciate this, right? On the data around processed foods and its negative impact on the brain. And we knew potato chips and Twinkies were not good for our waistlines, right? Not good for prediabetes. It's not good for your brain either. And so for people who are sort of on the fence, do I engage in these healthful behaviors or not? Because we have busy lives. They're hard to do. There are plenty of barriers to acting on that. Well, remember, your brain's at stake, your brain span is at stake. And so engaging on all those lifestyle things, even if you don't have a major concern, is brain healthy. So again, that's a little bit of a tangent, but I hope that answers.
No, not a tangent at all. That really important.
I was once working with somebody who said to me, "Oh yeah, this is going to be the part where you're going to tell me to live a healthy lifestyle, right? I should eat better, I should exercise more, and yada yada yada." Well, yes, but no. I mean, yes, that is the message that we're giving, but at Sunday Health, and I think for brain doctors in general, we also now understand the why that underlies that messaging. It's important to get good sleep, because if you don't, some of the body's other mechanisms that help to clear abnormal amyloid don't work.
Yeah.
It's important to exercise because, it's a healthy mind and a healthy body. I mean, there are reasons for all of this, and there's actually medical evidence that backs it all up.
Absolutely. And I think that's a perfect place to stop. Thank you so much, Dr. Ackerley, Dr. Sanders. So important to get a brain health baseline. I'm going to put up information on how to get in contact with us. Please send us your questions. Thank you for everybody joining today. We had a tremendous turnout. Really appreciate everyone taking the time out of their day to join us here. If you're in DC, Maryland, Virginia, we do encourage you to schedule. It's a no-cost introductory call with our nurse care navigator, and to learn more about our prevention and diagnostic brain health services. Again, thank you for everyone for joining. Thank you, Dr. Sanders. Thank you, Dr. Ackerley. There's more in the chat there, and feel free to reach out to